The way that I teach blood flow restriction is if you're not in discomfort, you're not doing it right. And that's very dichotomous, which the way that I view teaching and education is you have to simplify the complexity somehow, and then you layer in the complexity over time. So you create a framework, and then as long as the framework's sound, then you can kind of work in and etch in all the details. So the way that I teach BFR, it needs to be uncomfortable for you to really get a significant benefit. Why? Because we know proximity to muscular failure is important in muscle building processes. And it's actually more important when you're lifting lighter loads than when you're lifting moderate or heavier loads. So that concept is very much important. However, we do have evidence. For example, one of the studies back in 2018, they said, okay, because BFR is so uncomfortable, can we get a benefit by doing less?
It's a real pleasure to have Nicholas Rolnick on the show today. Welcome.
Thank you very much. Really looking forward to this combo.
Yeah, we've had already quite a few discussions. When I found you, I was so excited to connect with you. And it was a friend or another contact that led me to you. And you are the go-to, the OG BFR expert here. And you've written research on it. And you're just one of these amazing experts who knows so much about blood flow restriction training. And anyone who's followed me, they know I've been dabbling in many different types of devices for the last 5 years. And I have seen results myself, and the people who bought products, whatever they are, maybe whatever they are, they always get back to me with some results. And so I would love to break down a little bit what is BFR training, and then some of the risks versus benefits, and then talk to the menopausal woman to see if this is something for her. So let's start with just explaining in simple terms, what is blood flow restriction?
BFR, in its most simplest terms, is taking a cuff that's calibrated by some sort of technology, typically, whether it's computer or via a specialized Doppler ultrasound, if you really want to get a little crazy about it. And what that does is it reduces blood flow to the extremity in the simplest of cases. And that reduction in blood flow challenges muscles when you're doing day-to-day tasks or resistance exercise in such a way that, for all intents and purposes, it mimics what the intramuscular environment would be during high intensity strength training, except you're using little to no weight. And that has enormous benefits for a number of different clients, patient populations that may, for whatever way, shape, or form, be unable to lift heavier loads. And what we're seeing in the research is a rapidly evolving challenge to some of our understandings of physiological adaptation. So we're seeing that muscle can be adequately challenged. We see this in normal strength training research too, but we certainly see this in the BFR literature. We are seeing changes in the vascular adaptations. We're seeing changes even in tissues that we thought our current understanding thinks is unable to really be challenged with low intensity exercise, which are tendons and bones. We're really in a nice spot here when you look at it from the 10,000-foot view. But from my perspective, as somebody who is very much interested in the methodological aspects of BFR, it can be a little overwhelming because BFR is the hottest thing in musculoskeletal rehab right now, specifically in physical therapy research. So people are getting involved in the BFR research without really having a better than cursory understanding of BFR in terms of what we think it's supposed to be doing, different devices that can be applied to elicit the BFR stimulus, and et cetera, et cetera. So that's kind of where I'm at right now, is trying to shepherd the growth of BFR and the adoption of BFR, but at the same time, help in one way, shape, or form create research that's meaningful and impactful, that helps us make better decisions as clinicians if we're working with patients, but also just the everyday person who's might not want to lift heavy for one reason or another, and then be able to give them that opportunity to use BFR.
So I really respect the fact that you are working with clients. I always think clinical experience is gold. Research obviously is really important in having that structure, and you're doing both, which is why it's so awesome to have you on, because you not only understand the research and you write the research yourself and do these experiments, but you can use them in a practical sense in your clinic, which is ultimately what we need to know. Does this work it for the average person or not. And also, I just love the fact that you are finally the first person I'm inviting to the podcast for interview on blood flow restriction who is not selling a device because that's what I really wanted to get away from. Because when you interview somebody who's selling something, it's like, oh, it's all magic and it's all fabulous and there's nothing bad, and then we get all excited and we all want to buy the device. But I've learned over time that there are many different types of devices out there, and some of them have their advantages and disadvantages. But to explain a little bit, give people a visual on what blood flow restriction is, because you mentioned there are these cuffs that you put on limbs. So I've got one here. If you are on YouTube, you can see, just slip it and you put it on the just right under your armpit, and then there's another one that's like flexible. You could put on your leg. So it's either your arms or your legs, and you are, like you said, partially restricting this blood flow, or you're modifying it. And there's many different terms. So, and maybe you can explain the different terminology, because I've heard of targeted compression, partial blood flow restriction, modified blood flow restriction. What are there any differences, or is this all using the same different words for the same thing?
I think you hit the nail on the head. There's a lot of marketing that's out there. And the challenge with BFR is it hits a number of different physiological adaptations. And with that, there's a lot of knowledge gaps in even the most knowledgeable people, because you need to understand, for example, the stimuli that create vascular adaptations, the stimuli that create muscle adaptations, the hypothetical adaptations that are elicited from strength training to get tendon adaptations and bone. And there's a lot of areas at which you putting on a device, whatever that device may be, and the stimuli that it can produce to create whatever adaptation you're looking to get. So there's a lot of knowledge that's needed to, in my opinion, be really considered an expert in BFR. And that's what I think is the biggest issue from a mainstream application purpose, is understanding that it hits. You are, in essence, modifying, restricting, even in some cases, occluding blood flow to a limb, and then you are exercising in most applications. I would imagine you'd want to understand, if you're an expert, you'd want to understand what is a normal reaction to our cardiovascular system when we are exercising. And then you need to then understand what is the reaction when we are restricting or modifying or occluding blood flow and then exercising, right? So you can take all of what normally we should understand about exercise, and then you have to add another layer on what changes potentially with the application of a cuff to your limb that's modifying, restricting, or occluding blood flow. And that's where the complexity comes in. And so my job, or what I've taken on as my job, is trying to simplify the complexity as much as possible, and in an effort to help with global adoption of blood flow restriction, because I do think that BFR does have a strong place in the pantheon of exercise options that you can have if you're looking to certainly increase your muscle mass and increase your strength. But like anything, there are going to be pros and there are going to be cons to any sort of exercise regimen. If you think about it, high intensity strength training does not come without risks, right? We talk about the benefits, right? Improved in especially in the menopausal, postmenopausal female. We talk about improvements in bone density. We talk about improvements in muscle mass and the interrelationship between muscle mass and bone density and all of these positive benefits. But when we lift with high intensity, we are exposing our tissues to high load that could increase the chance of getting a musculoskeletal injury, right? That's just facts. And it's hard, right? Lifting heavy and lifting with sufficient intensity is hard, but that doesn't mean that it's not worth it, right? We need to consider at that point, how do we then get the most juice out of a stimulus? So with high intensity strength training, maybe we want to be more cautious about pushing ourselves to the absolute limit. Maybe think about exercise selection, maybe think about how our recovery is. And I hate that word, but it's the best word that fits what I'm trying to give an example of. And then we adapt and we program and we kind of overcome some of those deficits or those cons in strength training. And BFR is no different. And I think as long as we recognize that we are, in essence, applying something that is going to modify our blood flow in some way, shape, or form. And we respect that and we understand, hey, what are some of the potential implications of that? Is it safe? I think is the most important thing. And I would say yes. I think that BFR in general has been shown to be a very safe stimulus. But is it for everyone? Probably not. For a number of different reasons, not even talking medical. I'm just talking about psychosocial. Like, it's not a fun and pleasant stimulus. And if it is a fun and pleasant stimulus, you're probably not doing it right. Now, there are different ways in which we can make that stimulus maybe a little bit more tolerable, and that has to do with cuff design features. But in general, BFR is going to mimic what we understand about normal strength training. We need sufficient intensity, regardless of the load, to be able to elicit positive musculoskeletal benefits. Mm-hmm. So that means with high intensity strength training, we need to be operating in close proximity to muscular failure. That's uncomfortable. With low loads, we need to be doing the same thing. It's just going to take us a lot more repetitions in order to get there. So we understand the differences between how we apply our strength training stimulus to ultimately get to the same goal, of which BFR is simply another option that we can implement to be able to replicate that high intensity strength training stimulus.
Mm-hmm. Yeah, when you explain BFR and perhaps there is some risk and bring the analogy of high intensity training, yes, there's a risk, but that can kind of go for any sport, like pickleball or whatever people are into these days, golf. And I don't want people to go, oh, well, then it's better not to do sport because if you're sedentary, there's other risks as well. So I think it's just as we're aging, we have to always consider that maybe the risk of injury is a little higher or our tissues are taking a little bit more of a hit than when we were in our 20s. But with all things in consideration, I think we'd all agree that exercise, even with the risk, is still worth it and brings a lot more benefit than drawback. So you did mention recovery. I don't like that word. Why did you say that?
I think it's just the biggest buzzword in fitness and rehab right now. And I think we have yet to come to a consensus on what that actually means. Does that mean psychological recovery? Does that mean physical recovery? Does it mean both? And how do we measure those? What constructs are we using? What tools are being used to then say, okay, in this domain, we are now truly recovered? And I think this is another example of marketing coming before the science. For example, a common application of blood flow restriction is recovery, right? Recovery from what? From an exercise bout? Sure. How are we measuring that? Is this reduction in muscle damage? Is this getting back to being able to produce maximal torque in quicker periods of time? Right? These are all things that we just don't have a true consensus on right now. And I will say that repeatedly inflating and deflating cuffs does feel good. You get this nice tissue warming effect, great. But does the evidence truly suggest that there is a meaningful impact on quote unquote recovery? I think it's all over the place. And for me, as a goal of deconstructing the marketing from what we understand about the science, is that recovery is not the best application of blood flow restriction. However, is it a low threshold type intervention? Absolutely. Technically, I'm using Katsu right now for quote unquote recovery and vascular adaptations, because repeated bouts of restricting blood flow and then releasing it, that is a potent stimulus for vascular adaptations, angiogenesis, etc., which is just the formation of new blood vessels.
What is vascular adaptation and why would we want angiogenesis?
I think the more high, so if you think about how we live, and we live through oxygen. If we do not have oxygen, we do not live. And blood vessels carry oxygen through hemoglobin, and that hemoglobin has to travel through highways, and those highways are our vascular tissue. And then once we have these main superhighways, we call those conduit arteries. These are large diameter arteries that carry a lot of blood that then get distributed through smaller highways or parkways. If you're a driver around, you see the highway and then it goes to the parkway. The parkway would be just the arteries that then supply the muscles. And then within that, we have these micro highways or even just like streets and avenues that are off the major parkways. And those are supplying the individual muscle fibers. And that is extremely important from a health and longevity perspective because we now use that oxygen to create energy. And if we have an increased energy demand, then we now use oxygen plus anaerobic or without oxygen energy synthesis pathways. And as part of those, we now produce these metabolites. And these metabolites create these unpleasant sensations, and they are like that lactic acid burn when we do high intensity strength training, BFR, etc., sprinting, and we're like, oh my gosh, our limbs are burning. Well, that's just a byproduct of getting energy created really quickly. But those vascular highways, they provide an avenue for us to offload those metabolites and be able to get back to a baseline at a much quicker capacity. And that is health. Our being able to withstand a perturbation to our resting state and be able to get back to that resting state as quick as possible. And so now not only do we have the ability to get back to a resting state at a quicker capacity, but now our resting state is operating at a higher efficiency. And when we're operating at a higher efficiency, we can do more with less. And that to me is health. And so vascular adaptations can contribute to that by allowing for a better delivery of oxygen, a better utilization of that oxygen, right? They're correlated, but at least the vascular tissue is allowing for an offloading of those metabolites, the oxygen, et cetera, everything that's produced through energetic means to allow us to do more and be able to foster positive physiologic adaptation. Without that vascular adaptations, it is more of a challenge to our system to be able to perform at a higher relative level. So that's why I think the vascular adaptations are super important.
That's a really, I think people, hopefully they have their pen and paper and follow the pathway, because that is science, and this is what it means to be resilient. And this is the word that I'm feeling, is that, oh gosh, wow, you have your blood vessels and you have your arteries, and they're taking them to the muscles and the tissues, and then you have this metabolites, which are like this burn that we're going to talk about. And then if you have this burn too soon and too long, then you can't do your workouts as long or as well. So to try to give somebody an idea, imagine if you're going up a flight of stairs. You're in New York City, there's probably a lot of stairs in all these apartment buildings, and you're huffing and puffing and it's hard. But if you have vascular adaptation, or if you've trained, maybe going up and down the stairs all the time, you adapt and you're able to go up those stairs with less loss of your breath. Is that an analogy? Or
yeah, without getting too in depth in the physiology, we fail in exercise not because we can't handle the exercise, but we reach what's called a maximum tolerable perception of effort. And that just means that our brain reaches this critical threshold at which it will literally, as a reflex, shut us off. And our goal with strength training should be, we want to get as high as possible on that threshold with all of our adaptations. And thus we can then perform as high as we possibly can, right, for as long as we possibly can, to create a maximum physiological adaptation profile. So what happens with this is that cardiovascular exercise and unpleasant or cardiovascular response, so the higher heart rate, for example, and the metabolic stress, that unpleasant feeling, they feed into this algorithm that our brain then has to process that says, oh, okay, I'm still good to go, even though it's harder and harder and harder, because basically our body goes and says, all right, I can push this hard. I can't push harder than that. And so what we want to do, and getting stronger and stronger and stronger, is simply making up more of that difference so we can perform as high as we possibly can without exceeding that threshold, basically. So vascular adaptations allow us to reduce the cardiovascular demand, which will then reduce the interference effect to be able to take that threshold and maybe minimize it just a little bit. That allows us to get our resting heart rate back in between sets. That allows us to reduce those uncomfortable feelings, those metabolic stress type feelings, that then will allow us to perform exercise for longer and higher intensities. And so all of those things feed in. If this is very new to you, this is what I talked about in the beginning, which is a lot of domains to understand and appreciate before you even get into the BFR specific stuff, because the BFR specific stuff, for example, feeds into this because the high amount of metabolic stress that you're producing through repeated contractions and restricting that venous outflow means that those unpleasant feelings are inside of your limb for a lot longer. And that may, in certain circumstances, create a stimulus which gets us to our maximum tolerable perception of effort a lot quicker. And thus, in extreme or more extreme circumstances, we might not be able to fully stimulate our muscle to the same magnitude as if we were doing something in a shorter duration period of time. It's just a lot of domains that get hit from that perspective. But I think that is what's super important. And then obviously you have with the vascular, you have the correlations between longevity, mortality, morbidity, things like that. So the healthier we are in our cardiovascular system, the better we are at life.
Mm-hmm. How do we measure the adaptation? Is it just we can go push harder in our workouts or do another rep?
Which adaptation?
When you say vascular adaptation.
So you can look at a lot of different things. You can look, I think the simplest is simply measuring VO2. Your VO2 max. That is a.
How do you do that? Well, yeah, explain what that is and then how to do it.
So VO2 max is the most common measure that people use for aerobic fitness. It basically is the maximum amount of oxygen that your system can utilize in an exercise bout. And so when we're not fit, we're not able to utilize as much oxygen. This goes back to the example I said before. We're not able to utilize as much oxygen. So now we need more and more anaerobic or without oxygen type metabolism to be able to get us that energy that we need. And unfortunately, when you need energy quick, you now get these buildup of metabolites, and then ultimately at some point it burns too much, and then we stop the exercise. So we improve our VO2 max, we improve the time that we're able to, or the time/intensity that we're able to perform at a given workload. So if you're trying to cycle for whatever you're cycling at, you're able to do a little bit higher of an intensity at the same feeling. So it's not as hard to be able to work harder, basically. Why? Because utilizing oxygen is very efficient, right? It doesn't produce those uncomfortable feelings. And so VO2 max is an important metric because that, in essence, says that we can exercise at a higher relative intensity before experiencing that fatigue.
Yeah. So then I imagine different exercises or different maybe body parts even have different vascular adaptations, because it's just my workout this morning. I was in this HIIT class, a group circuit, and there was a man next to me, and I don't know, maybe he's about 45, and one of the exercises we had to lift a heavy weight over our head multiple times, I think about 15 reps. And he was just going pretty fast and heavier weight, obviously, than me. And I was like, oh, I'm kind of huffing and puffing. But then when we did the burpees, we had to do 15. I did them, no problem. He stopped at 6. So I'm wondering, like, does that mean the VO2 max is different for different exercises, even if it's the same person? Like even him compared to me?
Yes. So burpees are generally a more central cardiovascular type exercise. So they're going to, because they're large muscle mass type exercise, are going to elicit a larger physiological response. So that is more of a measure of your central VO2 max, but we also have muscle specific like VO2s. So like your biceps could be a little bit more conditioned than your shoulders and vice versa. So these are all, generally we think about VO2 as a systemic type response, but certain muscle, you can theoretically measure muscle specific. So what that example just tells me is that his shoulders, his triceps, his upper chest are probably more conditioned to be able to perform higher intensity exercise. But when you start to get into a central where you're having a ton of different muscles that are going to be activated, he's not as in shape. And so that's really why you get this conditioning response to resistance exercise, and you do get an improvement in your VO2 max. Why? Because your muscle specific VO2 increases. But when you do cardiovascular exercise, you're now increasing your central VO2 max. So your heart health, all of the central type vascular adaptations that allow you to get oxygen to different exercising muscles, etc. So they're a little bit different, as you pointed out.
So let's say he continues to train and goes to this class every day, and he goes from 6 burpees to 10, then to 12 to 15. Does that mean then, is that a measure of VO2? He can say, oh, now my VO2 is
You're basically saying that his work capacity has increased. So generally speaking, if I'm going to say that somebody's work capacity has increased, then necessarily they probably have increased their VO2 max. But the only way to truly measure a VO2 max change, you can either do it two different ways. You can do it the first way, which is probably the best way, which is to do a VO2 max test, which basically you're just trying to work to as high of an intensity as you possibly can, and you use specialized equipment to be able to measure your heart rate response to an increase in exercise workload. And then you get this value, right? Typically, pretty well-trained person is about 40 milliliters per kilogram. I can't remember the exact measurement. It's like 3 measures. And then you get to really train people that are 50 and 60, which are very intensely cardiovascularly fit. And you just want to make sure that you're above about 28 the value is about 28, because lower than that is associated with increased morbidity, certainly morbidity risk. I can't remember offhand if it's mortality, but I'm assuming it's probably both. So the average person is probably somewhere in that range. And so you train to get over that range, and then kind of feeds into each other. But I would assume that his VO2 max would increase, just given the fact that his workload, his work capacity has increased. Because if you think back to it, if he's able to utilize oxygen for a little bit longer, that's going to, this difference between where he was before and now, maybe 1 or 2, 3 burpees before his heart rate gets to the point where he's like, I got to stop. Mm-hmm. So that to me is an imperfect surrogate for VO2 max, but the only real way is to test it. And then you can do submaximal VO2 max tests, which basically you take 2 different time points. So you say, all right, I'm going to exercise at 150 watts, and I want to look at on a bike, and I want to look at what my heart rate is after 3 minutes. And then you then say, all right, I want to do 250 watts, and then I want to look at what my heart rate is. And then you could basically plot with the best fit line what the VO2 max would be at max intensity. So there are equations that you can use, programs that you can use as well to really get a little bit more of an estimation of what your VO2 max is. And then some of these exercise equipment adjuncts like Apple Watch or whatever, they can estimate your VO2 max based upon your heart rate at rest as well as your heart rate variability. So there's number of different ways.
Yeah. Oh, and that's interesting. Yeah, because when I think of VO2 max, I think of you get in a bike in a gym or clinic, and you have this mask on your mouth, and then they push you as hard as you can, and not everybody has access to that or can do it. So the other option of getting on a bike yourself, like you just explained, and testing your heart rate after 3 minutes is cool. But
yeah,
the easiest would be these watches or devices, and you don't have to do any calculations. But are they accurate?
Yeah. I'm not knowledgeable enough to know, nor do I care that much. So I haven't really looked. But generally, my understanding is these aren't the most accurate. However, they do give a reliable measure, meaning that they might not be valid. So they might not be they might not accurately prescribe the value. But when you use them as a reference point from today, 3 years from now, you'll get a general trend as to, is your VO2 max improving? You don't know how much, because it's not necessarily going to give you an accurate result, but it'll give you in the trajectory of between whatever it is right now to 3 years from now. It's the same algorithm, so it'll be able to give you a trend, which is what some of my clients use. Just generally like, hey, my VO2 max is improving with X, Y, Z.
If you put these things together, how do you feel? Are you training harder and you're able to adapt?
Just look at what you're doing on a day-to-day basis. Like I am a huge proponent of tracking everything that you do. Right? Because a lot of times I'm working with clients that have a history of injury, or they have a medical condition or whatever, and we're looking to see, how are you improving over time? Well, the only way to understand how you're improving over time is you track. Am I able to get 8 reps 2 weeks ago, and now I can get 12 at the same rate? Okay, that's progressive overload. Progressive overload is literally the way that we can appreciate and understand that positive physiological adaptation has occurred. We either can lift the same weight for more reps, or we can lift a higher weight with the same amount of reps. And we know that some sort of adaptation has occurred. Literally, it's impossible for it not to have occurred, given we've just increased the volume or the intensity of work that has been done. Yeah. And that is only visible through tracking.
Okay, we got to reel back to the BFR, because we got off tangent in talking about the vascular adaptation. And that's exactly what BFR can do, is give us these adaptations with perhaps a lighter weight, less risk of injury and things like that, or especially if you are coming after a surgery and all that. So why don't we talk about some of the other benefits? Because you've published over 60 articles on blood flow restriction, and you're also practicing as a physical therapist, and you've been working probably with hundreds of patients. So what are the benefits, the other benefits of blood flow restriction, and maybe which populations are benefiting from it the most?
And that's a large question. I think that anyone can benefit from blood flow restriction. Now, the scientist in me is going to say, okay, but the magnitude of benefit is going to be different in certain populations over others. And I think that the biggest bang for your buck population that is a home run population are those with knee pain, middle-aged adults. Why? Because generally the recommendation to lift high intensity is going to be met with, oh, my knee hurts. And I see these clients all the time. I mean, bread and butter. That and low back pain are my big patient cohorts. So you want to be able to create a stimulus that's going to continue to increase muscle mass. And I think it would do your listeners a disservice if we didn't at least discuss that muscle mass is not an aesthetic tissue. Yes, it looks great, looks hot, like muscle mass is great, but muscle is a metabolic organ, and it's an anti-inflammatory metabolic organ. So the more muscle mass that we have, the better we're going to be able to regulate our systemic inflammation. Knee osteoarthritis is, yes, it is a quote unquote wear and tear of the joint interface. But why does some people get knee OA that are symptomatic and others don't, even though they have the same x-ray? Right. So there's the hypothesis that there is just higher levels of inflammatory markers that are circulating in those that may be more symptomatic in their knee pain than others. Having more muscle is a way that we can combat that inflammatory response, but also improve our function because things get easier, et cetera. BFR allows those individuals to be able to get a significant treatment benefit from lifting light without the additional knee pain. And one of my colleagues, Edward Jacobs, out of the University, I think he's at Northumbria right now, doing a postdoc, some sort of experience there. But he published a paper that was outstanding. And what it did was they looked at the responses of a cohort of individuals with knee pain from osteoarthritis that they were looking at, does a regimen of BFR, and I think they used two exercises with BFR, single leg press and a single leg extension.
Do we know which type?
They use smart cuffs, which is a single bladder, meaning that's a traditional tourniquet-esque like BFR cuff. But I think the results would be, on constant. I think the results would be similar largely, and we can get into why and how we can ensure that. But in research, remember, we are adopting a paradigm and we are trying to create a homogeneous intervention. So in real life, it doesn't necessarily work out like that by design because everyone's their own person. But in research, what we're trying to create is a standardized stimulus, which for better or worse can give us guidance, but also inform us on potential pros and cons with that intervention. But what they did was they basically did 12 weeks of BFR, and they had another group that didn't do BFR, traditional low load strength training. And not only did they find significant benefits at the end of the 12-week program, they found it at 3 months. And they found it at 1 year following the completion of this 12-week program, which is insane.
That's
the fact that exercise alone, if I didn't know the author personally, and I would have skepticism as to the validity of even the project, because in general with exercise, it's not going to be maintained once you stop. So there is a lot of hypotheses as to why that's the case. But the biggest thing that came away from that 1 year follow-up was that there was like a 63% reduction in medical intervention in the BFR group for injections. So this is massive from a physical therapy perspective, from trying to have a self-management perspective, that a 12-week course of BFR could have impacts extending to a year. And
was it daily? Were they using it every day or
a couple times a week? A couple times a week. I don't think there's only a select amount of interventions that you could use daily with BFR. I think that if we adopt the paradigm, which I believe is going to be the correct paradigm, and the one that I hypothesized over 5 years ago, is that BFR is simply strength training accelerated. So all we're trying to do is we're trying to replicate a high intensity strength training environment. We can do that with low loads, but it takes a lot of reps. With BFR, we condense that process entirely. And so we can lose a third to two-thirds of the total repetition volume in order to get that strength training effect that mimics high intensity strength training. And when we look at the research that has actually kind of tried to tease apart the intramuscular environment between low loads of BFR and high intensity strength training, we actually find that at task failure, the environment in the muscle is identical. And that kind of provides an explanation as to why BFR can produce an equivocal stimulus as high intensity strength training. Because and this is also low loads as well without BFR, but it just takes a lot longer to be able to do that. But when we actually zoom in and we look at the environment at 25% of the reps to failure, 50% of the reps to failure, meaning that if I do 100 reps in low load and I do 10 reps or 12 reps at high load to reach failure, and then I do 50 reps at BFR to reach failure, right? When you zoom in at 25% of that, so whatever value that is, so 25 reps at low load, 3 reps at high load, and then whatever the BFR is, 50% times 0.25, whatever that is, the environment is identical.
And the environment meaning what?
Meaning the intramuscular environment, the amount of tissue deoxygenation, largely, at least with low loads to low load BFR, the muscle activation is similar. You're obviously going to get a different muscle activation pattern with high loads, which is why it's a little bit more fatiguing and we fatigue out quicker, right? We need more muscle fibers to be recruited at that particular time. But in general, when we look at the quote unquote ingredients to allow single fiber tension, which is really what we're trying to do when we strength train, is to stimulate this overlap of actin and myosin, which are the contractile parts of the sarcomere. We want to overlap them with slow movement speeds. When we do that, we create what's called mechanical tension, which is this kind of abstract quality, but generally we have these sensors on the muscle fiber, keeping it very simple, that register this pulling force then gets translated into muscle protein synthesis, and thus we get this directive from this stimulus that says, we need to put down more muscle mass in this particular area. And so we rinse and repeat that over time, and we get this visible increase in muscle mass called hypertrophy, and that's the adaptation profile. But what's cool is we can replicate that with BFR. So we don't need, circling back to the osteoarthritis example, is with the challenge with osteoarthritis and those with symptomatic osteoarthritis is joint pain following exercise. We know that exercise is beneficial, but during the exercise, like especially we have the immediate effects of load, which are pain during loading. And then we also have the reactive response, which are the days after, where the knee is a little bit more intolerant to putting weight through because of this increase in load. We can now get around that with using blood flow restriction, because now we're reducing the absolute mechanical load that's going through the knee joint, but we're still creating that intramuscular environment that mimics what we would get with higher loads. So we can reduce the overall joint related pain or swelling, and we see that with BFR interventions compared to high intensity strength training. And that's also reflected in the cessation rate. So the people that quit tend to be the people that in this population are lifting with higher loads because it hurts more. So that's where I think that this home run population can, for better or worse, knee osteoarthritis is a pretty common condition across middle age and older adults. So it can fit a large umbrella of those patients.
Yeah, unfortunately, osteoarthritis is quite prevalent. And I had hip osteoarthritis for many years. Now I have the 2 hip replacements, but I know that knee osteoarthritis appears much more in the knees than actually the hips. So I think you've hit the nail on the head with that population. And boy, yeah, I was so happy to have BFR in my life. And anyone who's been following me, they know my story is that as I was gradually declining and could do less and less range of motion, I would still always try to do my rehab and whatever I could, the limitations, but I was wearing those bands every single day. And because I just thought, I just don't want to lose my muscle mass. And so the question is, it sounds like quite an amazing thing if you're looking at muscle mass. And I want to stress again, like you said, muscle is your metabolic Spanx, and it's such a great tool. It's not just about looking good. It's about so many other things. But in our community, we have plenty of people hearing about the benefits from physios or people who've had surgeries. And they go, well, why can't I just use these BFR bands? I don't have any of those things, but I don't really want to go to the gym, or I don't want to lift that heavy, or I'm scared, or whatever. There's many reasons. So they want to use this as a replacement for exercise. What would you say to that?
I mean, we have a crisis, probably, I certainly know in the United States, but probably internationally, that people are more sedentary than active. So for me, as a physical therapist, personal trainer, as somebody who is generally enthusiastic about the positive effects of exercise in multiple different domains, physical, psychological, etc., I don't have a problem with that. I think any way that people can adopt a higher physical activity value than they currently are at is going to be beneficial. Now, do I think that as a sole difference in the long-term way that BFR could be used? Sure, but I think that there are probably that gets into what type of BFR cuffs do I think could be better long-term solutions that mitigate the very low safety risks associated with chronic use. That would depend on the person's health, what they want to invest in a cuff, and their tolerance for risk.
Mm-hmm. Okay. I always say it's a great add-on. I try to encourage people to exercise as much as they can. But if you can't, if you were like me, then I think it's so great. And I'm thinking also of my 85 or no, 89-year-old father-in-law now. He's not moving around. He's not going to the gym, and he's just not going to be able to. And I thought, well, it'd be nice. I think he could easily put on some bands and get around his house or doing something. It would be better than nothing, is my opinion. But I think I do see in my community with whatever bands people are getting that they do see some the pump or a bit of the adaptations, and they seem to work. But the question I get so often is, which bands do I buy? And I've been learning through you. You have a fabulous program, online program to teach physiotherapists on blood flow restriction, and you go through the science. It's really fabulous. And I would love for you to explain the differences, because I started out with the old Amazon, just a band. And then I got scared. I'm like, no, let's go get something that's a little bit more sophisticated. And then I found the one that looks like a blood pressure pump, and you have the pump there. And I was learning how to do that with somebody who was teaching me. And then eventually I used the ones that have a cyclical mode. And there's just so much out there. And I don't understand wholly the differences. And I would love to explain them so that other people can decide what is going to be the best choice for themselves. And mind you, there's variability in cost as well.
Yeah, I think the way that I classify different blood flow restriction cuffs starts out with the overarching classification of pneumatic versus non-pneumatic. So non-pneumatic are the traditional like Amazon straps. They are not inflated with air. They are simply fastened on the limb. And the recommendations for those types of devices are a 7 out of 10 tightness.
10, wait, 7 out of 10. Oh my God. How do you
10 is
decide?
the maximum, 10 is the maximum tightness, 7, and that's where there's just a lot of subjectivity with that type of prescription. And what we understand about the research on 7 out of 10, it works, right? It works. Why? Because you are restricting or modifying or occluding in whatever capacity you're doing blood flow. That's intensifying the current exercise, making the muscle work harder to generate a contraction to then create a little bit more mechanical tension per repetition and get us to that point of high effort, which is going to stimulate muscle mass, right? So they work.
But there are risks, aren't there?
But the risks, and I think a lot of the risks come with this absence of education on the tolerance of our physiology to adapt to a temporary intensity change in our peripheral tissues. I think that the risk of a practical, and that's what it's called in the literature, practical BFR, because you're not using a pneumatic cuff that inflates. I think the risk is more consistency. And when you don't understand the amount of pressure that you're applying to the limb, you get an inconsistent stimulus. And it could make it harder than it needs to be in order to get you that benefit. I think there are easy ways to help increase the safety of using some of those devices, which are simply making sure you have a pulse in your extremity after, making sure that you're not experiencing numbness or tingling, right? Those are sensations that mean that the nerve is getting impinged and are early warning signs for you to reduce the pressure. Those simple enough will allow for a relatively safe application of BFR. Do I think it's optimal? No, because if I'd rather, as a researcher, as a clinician, as somebody that teaches other people how to do blood flow restriction, I'd rather be more rather than less objective. So in that case alone, I don't recommend practical BFR. But if anybody tells you that it doesn't work, is out of their mind, because it clearly works. There's at least, off the top of my head, 5 to 7 papers that are using practical BFR that either show a chronic benefit of its use in a 6 out of 10, 7 out of 10 pressure scheme, or acutely replicating the same type of physiologic responses as pneumatic cuffs. So it's not a risk from a safety perspective per se, as long as you're taking common sense precautions. But the non-pneumatic cuffs are annoying to apply, especially when you're talking about the upper extremity, because you have to fasten it. It has to have a specific type, especially if you're using powerlifting straps or other things where it's not as intuitive. And they tend to be narrow, so they're not actually being able to restrict or modify blood flow in any significant capacity. So that's where my line in the sand is as an educator, is I'd rather be more rather than less objective. And then you get to the pneumatic cuffs. These are the cuffs that are inflated with air. And for me, there's 2 different categories. There's the automatic, and then there's the non-automatic cuffs. So the non-automatic cuffs are the cuffs that you manually inflate yourself, and you have to determine, if you're trying to keep up to current evidence, standard of practice, you would have to determine a relativized pressure of some way, shape, or form. That means that it is a pressure that allows you to exercise between, what's currently recommended is between 40 and 80% of the pressure that is needed to fully occlude both arterial inflow and venous return. And then you exercise at that percentage. So it allows for a moderate reduction in blood flow. And in order to do that, traditionally, you're using something called a Doppler ultrasound, which basically is a device that you put on an artery that's distal to the applied cuff, and you inflate it, and then the sound goes away when you've now, in essence, completely occluded the blood flow, because it measures the it basically measures the arterial flow, and it bounces back a sound wave, and then you can kind of measure it accordingly. And then you operate at a percentage of that. But that's practical for only a small percentage of people, because you typically are going to need 2 people to be able to do that. So that makes it only feasible for environments where you're either exercising with somebody else, or you're a physical therapist, personal trainer, or whatever, where you're able to then use that with your clients or patients. So that is the non-automatic version. So there's a little bit of a cumbersome aspect to that. As I am going through this, the price is increasing, right? So
yeah. I think Amazon bans are what, like,
yeah, it comes from
20...
like tens of dollars to now we're at the phase where it's hundreds of dollars. And so the automatic cuffs are cuffs that are utilizing some sort of computer algorithm to be able to determine the amount of applied pressure. And it's important because this takes out the user error, so to speak. But if we're adding a layer of complexity here, just because a computer algorithm is telling you the amount of applied pressure doesn't necessarily mean that it's accurate. So there are validation studies in some of these algorithms that need to take place in order to confirm that, hey, this is actually the amount of applied pressure that I am giving, right? And then you make those kind of determinations from there as to whether or not you feel comfortable with devices that may not have a validation study to support its use. Now,
I'm trying to think of the person who is thinking of this for their father or mother, and they're a bit older, maybe they have heart conditions. Would it be like, if it's not consistent, is it a bit more dangerous for somebody like that?
So generally, you would need to just assess your limb occlusion pressure 1, maybe 2 times, and then you just use a percentage of that over a period of time. It's not like you need to assess it every single time. The research really shows the LOP doesn't change significantly over the course of 6 to 8 weeks. So it's not really a measurement thing that you need to hit all the time. But what we do understand is there does appear to be a minimum amount of applied pressure that needs to be inflated on the limb to be able to meaningfully accelerate the fatiguing processes to occur. There's a meta-analysis by one of my colleagues back in 2021 that said that we probably need, at least in the lower body, about 50% limb occlusion pressure or more in order to meaningfully accelerate repetitions to fatigue over a low load exercise condition alone. So that would be the minimum in the lower body. But I will say that those type of analyses are limited by the studies that were done at the particular time. So I've done work that has looked at different types of cuffs, specifically the bladder design, meaning that when we're talking about traditional BFR cuffs, and this is of course an aside to the automatic aspect that we're categorizing that we're doing, but this is germane to our discussion. So when we think about traditional BFR cuffs, we think about cuffs that have one bladder, meaning they're traditional tourniquets. They are designed to occlude arterial and venous blood flow.
So it's like a blood pressure cuff, like giving people a visual,
like a blood pressure cuff. People thinking limb occlusion pressure, this is not a foreign concept. Limb occlusion pressure is your blood pressure. If you were using a cuff that is of identical material and width as the cuff used to determine your blood pressure. So, for example, like if this cuff is probably around the same width as your blood pressure cuff, this should give a value that's probably near your blood pressure if you were going to measure this in your arm. Versus something like this or this, which is more narrow, meaning that it's going to require more pressure in order to get that occlusive stimulus in your arm. So that your limb occlusion pressure will be higher than your blood pressure using a cuff that's narrow versus a cuff that's very wide, for example.
Yeah, that's kind of like these two, if you're looking on YouTube.
Yeah, so if you look at the band on the right-hand side of the screen, that would take a higher amount of pressure to occlude blood flow than the cuff on the left, which is wider, so that will acquire less pressure. So standardizing according to the cuff just means that you're applying a relative pressure so that the magnitude of blood flow reduction between those two cuffs will be identical if they're inflated to a percentage of limb occlusion pressure that's relativized to that particular cuff.
So that's just to understand quickly. So if you were to say with the wide one versus the narrow one, 50% means something totally different.
Yes. 50% will be a higher pressure in a narrow cuff than it will be in a wider cuff. So there are thoughts that you want to use a relatively wider cuff if you're using a traditional Western-based rigid type apparatus, but the research really shows that when they're inflated to a similar percent, the physiologic stimulus is largely the same. So this is more of a method to standardize the research rather than it is to standardize the practice, which I think is really a huge barrier right now, is because you have companies saying one thing, research saying something similar / maybe a little bit different, and then you have a consumer that's not super knowledgeable in general and then are being told a certain narrative and are assuming that is the correct approach and nothing else really works. And I think the totality of evidence on BFR using a number of different applications, whether it's KATSU, whether it's practical BFR, whether it's pneumatic, automatic, etc., shows that it is extremely safe and well tolerated by even the sickest of the sick patients. To give you an example, I was at Combined Section Meeting, which is the largest meeting of physical therapists, and this was back in 2022, and there was a BFR presentation, and they showed individuals that were mechanically ventilated in the intensive care unit cycling with blood flow restriction in ICU beds. Okay. So the reason being is because muscle atrophy happens very quickly when we are immobilized, very quickly. It's not relevant to us walking around and moving around and not exercising, because we'll still lose muscle between periods of exercise, but it's meaningless. When you're lying on your back and you're not moving and you're not weight bearing for a period of time, that atrophy is very quick. And so when we think about it, we basically have a good day where we're not having any atrophy whatsoever. When we're bedbound, 48 hours, we start to have changes in our insulin sensitivity. Day 3 to day 5, we have MRI evidence of atrophy. So it happens very quickly. And so the goal here is, when you're immobilized, is to try to do whatever we possibly can to mitigate that atrophic processes to occur. So that's where the passive BFR can potentially come into play, because it's not anabolic. The pump is not anabolic. The pump is probably anti-catabolic, meaning that it upregulates or it downregulates genes that are promoting atrophy. So if we can downregulate those genes, tamper the genes from being translated and expressed, well, then we can potentially save off and reduce the magnitude of atrophy that's occurring through immobilization or bed rest. And that's really what we see in these type of studies. But we generally need contraction to have a meaningful impact on our atrophy. And so there's a well-designed study back in one of my colleagues in Europe, Cass Fuchs, and they basically had people on bed rest for 2 weeks doing passive BFR 3 times a day and showed no difference in a myriad of muscle-related factors, including cross-sectional area, that basically just made the case, which I've been preaching for years, that we need to contract our muscles in order to have a meaningful impact on stimulating muscle growth.
What is passive BFR?
What you described initially, which is simply applying a cuff and doing cyclical rounds of inflation and deflation. But the benefit of something like the KATSU, which is a programmed inflation deflation, is we're able to go about our day-to-day life and do whatever we're doing. So we're creating some sort of active muscle contraction, which creates a vascular stimulus in and of itself, just given that we are increasing oxygen demand. So things like this, where I'm just moving my arm, talking around, whatever, and I have the bands on. The program ended probably like 30 minutes ago, but when it was active, it is creating a situation where, yeah, I'm contracting my muscle, for example, but I'm now relatively occluded in some way, shape, or form. So it's increasing oxygen demand. So it is doing something that is beyond my day-to-day, which is why these programs could have some benefit for individuals that are largely sedentary. But the benefits of something like a passive BFR application with KATSU is for someone who's super active, and I'm not as active as I used to be, just given that I'm still recovering from COVID and the effects of long COVID. And unfortunately, I had a little bit of exercise intolerance. It's better now, but still taking it very slowly. But someone who's very active, who's using this, is probably only getting a small vascular benefit of using KATSU due to the repeated inflation and deflation cycles, because they're already getting a benefit from exercise itself on the vascular tissue and the muscle tissue, et cetera.
So just to clear up for some people, so the passive meaning there's a cyclical mode, because when you put these bands on yourself, and you explained, you have this constant mode, it's stuck, and you put in the air, you pump it up, or it's automatic, and it's just there, and you wait. And some people do 10 minutes, some people do 5, some people do longer. It depends on the percentage of pressure that you can tolerate. And then we have, you mentioned KATSU several times. KATSU is a brand, and this is a band that has a cyclical mode, but there are other bands that have the cyclical modes. But I think maybe you can talk here about the differences between, say, a rigid one that's stiff around your arm and then one that's a little bit more flexible, like KATSU. And KATSU is that flexible one. I don't know if there are any others out there that have this flexibility and the cyclical mode, but what is the difference between, let's say, KATSU or those kinds of bands versus others? And you could talk about just rigid.
Yeah, I mean, I think, well, let me just finish the classification system. Yeah. We have automatic cuffs, and then within all of this, we have bladders, which I mentioned before, which house the air that's applied to the limb. We have single versus multi-chambered, which are just sequential bladders, right?
Oh,
if you look
so there are multiple bladders in one.
If you look at the difference between here, and I'll see if I can inflate this.
What would
see? So
why would you want to have multiple bladders?
This is designed for safety and comfort, but it's at the expense of efficiency. So one sec. So if I pump this up, you can see here how there is multiple sequential bladders that are connected, but there are pieces that are not inflated. And what happens is when it goes around a limb, there are periods of or areas within the cuff that are not inflated on the limb. So what this does is it reduces the magnitude of applied pressure to the exercising limb. So it is by design not a tourniquet. That is what this type of cuff is marketed for. And as a result of that, it's safer because you're not getting any significant arterial restriction. And the research does support that, in the sense that the recommended pressure that for these cuffs are much, much higher, not because that's the cuff pressure that's applied to the limb, but that's just the pressure within the cuff itself. And it's not designed to restrict arterial flow. So when I mention efficiency, it just means that it's not as effective to reducing the amount of repetitions needed to reach volitional failure. So my research, we've compared in the upper body and the lower body, we've compared a rigid cuff, which we use the Delphi personalized tourniquet cuff, but it's basically the same thing as this. It's a little bit more, and same thing with the cuff there, is that when this inflates, it inflates circumferentially around the limb to apply a relatively symmetrical pressure, where we inflated it to 60% of supine limb occlusion pressure, which is on the lower end of what we would use in practice for exercise. And we found that at least in comparison between a cuff like this might be slightly more tolerable when we have them exercise to failure, but it does take significantly more reps than it would be to get to failure with a single chamber cuff. So it's a less efficient. But do I think that over the period of time that the benefits could be significantly different? Potentially. I think that it depends on the protocol that's adopted in the training, but we already have evidence that suggests that we might not need as many repetitions as we currently think we need in order to elicit hypertrophy that's similar to high load exercise. Some of the work that we did was we meta-analyzed the repetition schemes that are commonly used in BFR. So we did 3 to 4 reps, 3 to 4 sets of 15 versus the traditional recommended 30 reps followed by 3 sets of 15, and then multiple sets to volitional failure. And we just compared it to trials that implemented high load exercise. And what we found is the hypertrophy in largely untrained people. So these are not athletes, but largely just healthy, recreationally active individuals. The hypertrophy is the same, whether or not you're using 3 to 4 sets of 15, 4 sets in the traditionally fixed 75 repetition protocol, or multiple sets of volitional failure. That means that regardless of the BFR that was adopted, the hypertrophy was similar. So for me, as somebody who's interested in trying to lower the barriers, I think that we don't need as long as we're over time trying to progressively overload, I think we can feel free with starting as little as 3 sets of 15, as long as we're trying to increase the load over time or increase the volume to maybe 4 sets of 15. There is a continuum of repetitions that can elicit similar adaptations. So we might be able to do more reps, but we might not need to, because the stimulus at which we're signaling muscle growth has actually been saturated. So the only thing that we're doing at that point is just adding to our misery and discomfort by doing more and more repetitions. So that's part of my goal as a researcher, but also as a clinician that's seen the benefits of BFR, is maybe we can do the same with less. And I think the barrier to long-term blood flow restriction adoption is it's uncomfortable. It sucks. It's not pleasant. So can we make it a little bit more comfortable but get the same benefit? And I think that really is an area that's ripe for future research.
Can I ask you about the multiple bladders versus a single bladder? Now, you explain the differences, and that's fine, but are there any price differences between those?
I think we're operating on hundreds of dollars. These are not thousands of dollars, but when you get into here, these are $400, $500. This is a single chambered cuff, smart tools, but you get into, they're largely similar. The difference between this is because you're not restricting meaningful arterial flow, you can actually put these on all 4 limbs. So you're able to intensify the stimulus. I used to be very against these just from a purist perspective, because I was very much biased toward single chambered cuffs being very efficient. But I think we have enough evidence, even if it's not the best design studies, I do believe that these things do work. They might not work as well as a single chambered system, but they do appear generally a little more tolerable. So for a fitness perspective, I actually don't mind recommending these cuffs if people are like, yeah, I'd rather not have to worry about the safety aspect of occluding arterial flow, because I know that arterial flow is not going to be meaningfully occluded, particularly at the prescription that they're going to be applying it at, which is anywhere from 250 to 350 millimeters of mercury, which would be extremely intolerable with a single chamber cuff, but is generally just feels like a little bit more than compression with a multi-chamber cuff. And then you can just go about your day to day and do your thing, and you're not really restricting meaningfully arterial flow. So it's not a safety issue, versus if you're using a single chamber cuff, that especially a rigid single chamber cuff like these, not as much Katsu, because Katsu is more of a elastic type material, so it has give to it. But if you're using a rigid type cuff, then yeah, you probably need to pay a little bit more attention to the amount of applied pressure that you're using, the duration of the stimulus, and really a little bit more to the peripheral responses, because you are creating a significant vascular occlusion, vascular stimulus, depending on the amount of applied pressure, than you would be with these other cuffs. So I think that the majority of BFR applications are super safe, but it goes back to how can we, if BFR is going to be adopted in a in a long-term basis, how can we make whatever BFR cuff that we decide to implement, how can we make it as safe as possible and reduce the barriers to its successful implementation? And that's really a task that I've taken to heart for my own practice as an educator, as a researcher, and as a clinician.
Are there any other categories? Because you did mention the flexible category, and that's Katsu. Are there other bands that are flexible, or is it just Katsu?
These are the Be Strong. These are elastic as well, but the difference is Katsu is single chambered and the Be Strong is multi-chambered. But generally, the way that I classify BFR, it ends at kind of the automatic, and then there's, even within the automatic, there are cuffs that regulate the pressure during exercise. So these would be called automatic auto-regulated, and then it separates into automatic unregulated. And so there's these more expensive. You're getting into the high hundreds, if not low to mid $1,000 applications. And there is the notion that auto regulation may enhance the stimulus of BFR just by, you have these rigid cuffs that don't adapt to the pressure from the limb to the cuff. Why? Because remember, if I'm doing a bicep curl, I have the cuff is staying there, but my limb is pushing up in various capacities into the cuff. So the rigid cuffs don't adapt. The rigid auto-regulated cuffs do adapt. They dump out air when the muscle presses up against the cuff, and they inflate when the muscle is in the eccentric or the lengthening part of the contraction to try to maintain a stable pressure on the limb. Now, that is another area that I'm highly interested in because it's marketed as a way to effectively apply BFR. I haven't been convinced that auto-regulation is a relevant feature. I've done now 3 papers on auto-regulation, and all it does is open up more questions, because not only do you have to consider the auto-regulation as a variable itself, but then you have to look at the responsiveness of that auto-regulation. So for example, if I'm using a cuff that's not that responsive, then you're basically creating a situation where the blood flow can escape and you're getting less BFR stimulus per repetition because the device is not able to apply a standardized pressure in quick enough circumstances. And then you get this very responsive BFR cuff that is adaptive, like the Delphi personalized tourniquet cuff, that is a rigid, little bit wider of a cuff, and it is able to adapt very quickly because it's a retrofitted surgical tourniquet device. But we find that once it's able to adapt very quickly, it doesn't really change the end result much. Meaning that if we just have that cuff that's inflated without auto-regulating, and then we have the same cuff that's auto-regulating, it doesn't really change the outcomes acutely from the applied stimulus. And in fact, we are just submitting a paper for publication that shows that auto-regulation doesn't have an impact on long-term muscle mass and muscle strength gains, and they change perceptually in terms of over the course of a training cycle, 8 weeks, very similarly. So it is a feature that is marketed that right now there is minimal evidence that suggests that it's truly a game changer. Do I like auto-regulation? Yes. I
Is
think
it more
auto-regulation,
comfortable?
not really. It really depends on the device. So it opens up more questions than actual answers. But we're in the process right now of collecting data that's comparing now 2 different auto-regulated cuffs that's inflated to the same pressure. And we're going to look at repetitions to failure. We're going to look at muscle deoxygenation, perceptual demands, cardiovascular demands, to try to paint an acute picture to the differences, because that's really where my research is going, is comparing all these different features and seeing which ones are relevant, which ones aren't relevant. And if they are not relevant, okay, great. If they are relevant, okay, how do we adapt that to practice?
Yeah. So if the bands that are flexible, is that considered somewhat auto-regulated, or not.
Not really. The material in and of itself just means that it's able to adapt and it's not actively adapting, if that makes sense. Auto-regulated means that there's a computer program that's actively looking at monitoring to its current capacity. I don't want to get more complex, but there's something called an interface pressure and a set pressure. Set pressure is the pressure that you're applying, that you're saying, all right, I want to apply 200 millimeters of mercury to the exercising limb. The interface pressure is the pressure that's applied from the cuff to the limb. It may be 200 millimeters of mercury, it might not be. And certain cuffs have different abilities to regulate the interface pressure. So that means that the stimulus of BFR is very consistent. Do I think that has a meaningful impact on practice? No. But autoregulation, at least in the definition that I'm using, which is actively regulating the pressure, the material simply just allows for distribution of the applied pressure around the cuff that fits, like a contraction, versus a auto-regulated cuff would be dumping out air during the contraction and dumping in air and pumping in air in the lowering or the part where the muscle is not bunched up against the cuff. So one is a very active process, one is a passive process. So the Katsu, the B Strong bands, even the other cuffs, they're just distributing the same amount of air within the cuff itself. Mm-hmm. So it's different. One's an active process, one's a passive process.
So what I'm gathering from this whole discussion is very conclusive to some of my experiences is that you'll get from point A to point B. That's They all work. And this is the feedback that I get no matter what device I'm recommending. People are getting results. Now, the difference is a big difference that I think will help people or decide is comfort and then price. You may decide because on price is more important or comfort. And I imagine the more comfortable it is, then the more expensive it will be. But as a physiotherapist, you also want your clients to be using this. And if you're not using it because it's so uncomfortable, but you also mentioned earlier, if it's not hurting or you're a little bit too comfortable, it's not working. And it reminds me of some of my experience when I was really not able to do a whole lot. I was doing the Katsu every single day. I was like, oh, I don't feel as much pressure. And when I started to try some other cuffs after I recovered, I was exercising with the constant mode with a wide band, with the Suji ones. And I got gains with both of them, but the constant mode is painful. And I think, oh, I can't stand it more than 10 minutes. And I'm like, I got to get these things off. But within 2.5 weeks, I had measured through a body composition scale, whether you consider it accurate or not accurate is debatable, but I had increased my muscle mass and decreased fat in 2.5 weeks. And I thought, is it because it's more intense and it's doing the same thing in 10 minutes as another band would take 45 minutes? Or is it just I'm not doing a study that has checking all the variables?
Yeah, I think it's N equals 1 are great, but they only tell part of the story. If you're never going to be in that same spot again where you leverage something like the Katsu and did that same thing. So you don't necessarily know because you're not going to be able to replicate that exact experience. So N equals 1 things in form of some sort of efficacy associated with that. You got a benefit. That's amazing. But that's really why we do randomized trials is we get a group of people that are like yourself and we put them through the same intervention and we randomize 1 to Katsu, 1 to your Suji cuffs, and we follow them through a 2.5 week, 3, 4, 5 week, whatever it is, program. I think of everything through a strength and conditioning lens, and that informs basically everything that I teach about BFR. And so for me, I think the window is very wide. I think it's wider in very sedentary people and it's narrower in more trained people, but more trained in whatever mode of exercise you're using, aerobic or resistance exercise. So in terms of resistance exercise, we might not need as much pressure. We might not need as many repetitions to elicit a positive benefit. So it's hard to say. All I know is that if we're able to accomplish exercise to produce some sort of stimulus over time, and as we get more and more of that stimulus, so more and more reps, for example, or higher load, we should produce a physiologic adaptation. What's cool about the blood flow restriction is, and I have my hands in, and I don't say this just because I feel like I almost come across sometimes as like I know everything, but like I just have my hands in a lot of different pots in the BFR realm. So what you described over 2.5 weeks, and you're probably doing it every day, is something called high frequency blood flow restriction. And high frequency blood flow restriction is marketed as a way that, because BFR doesn't induce significant amounts of muscle damage, caveat, there's an asterisk there, because in certain situations it definitely could, but in most circumstances it doesn't. You can then create musculoskeletal adaptations at much quicker capacity because you don't need the time to repair the muscle damage in the muscle before you stimulated it again. And a colleague and I that I frequently collaborate on papers with, Victor de Queiroz, he's in Brazil, and we did a scoping review of the high frequency BFR literature that people say, oh, you can do BFR every day and get benefits. We did, I think it was 23 studies, and we showed that, yeah, overwhelmingly, blood flow restriction outperforms low intensity exercise without blood flow restriction when we're doing it multiple times a day over less than 3 weeks. But this is an example of a situation where all the studies that have been done, there was only a handful of studies that actually used adjunctive statistical analyses, like looking at confidence intervals and looking at effect sizes. And a lot of them just reported P less than 0.05, which for the non-scientific reader says, oh, group mean or the change is statistically significant between pre to post or between groups. And that's great. But a statistical significance doesn't necessarily mean that it's clinically relevant. And that's where you use secondary statistics like confidence intervals, so the overlap of the data points, 95% of the data points you'd expect, or effect sizes, the magnitude of group change from pre to post. And a lot of the BFR literature right now says, yeah, BFR works, but we don't necessarily know how much. It's like walking in a direction. We know that it works, but we don't know. We can't like precisely go to a particular destination. We're like, oh, it works. We just don't know how well it particularly works. And I think that is one of those situations, to relate it back to your case. If you're going to do BFR compared to no BFR and you're going to do the same exercise, regardless of whatever pressure you're going to be applying, I would think that the BFR is going to outperform the exercise without BFR. How precise do you want to get in alignment with the current body of evidence? Well, that's up to you. That's up to your pocketbook. That's up to your tolerance, because certain exercise recommendations are going to be a lot more intolerable than others. But I do think that the window is large enough that it wouldn't surprise me if you did different cuffs and got the same benefit despite different pressure schemes.
I'm just trying to think, and this happens, these are questions in my community as well, is if I if I'm feeling some benefit or whatever with this pressure or this length, then more is more the better. So when I have the katsu, I'm thinking, oh, well, I could go on all day. It doesn't feel that intense. If you're on the cyclical mode, and if you're of a cycle mode, it's different. But if I'm doing something cyclical, you're like, oh, okay, but is it really doing anything? And to me, it did. But then the question is, yeah, is it gotta hurt for it to work better or more?
That's $1 million question, because for example, the way that I teach blood flow restriction is, if you're not in discomfort, you're not doing it right. And that's very dichotomous, not right. Which, the way that I view teaching and education is, you have to simplify the complexity somehow, and then you layer in the complexity over time. So you create a framework, and then as long as the framework's sound, then you can kind of work in and etch in all the details. So the way that I teach BFR is, it needs to be uncomfortable for you to really get a significant benefit. Why? Because we know proximity to muscular failure is important in muscle building processes. And it's actually more important when you're lifting lighter loads than when you're lifting moderate or heavier loads. So that concept is very much important. However, we do have evidence. For example, one of the studies back in 2018, they said, okay, because BFR is so uncomfortable, can we get a benefit by doing less? And what they did was pretty cool. What they did was, they looked at exercise, and I can't remember if it was a leg extension or a leg press. Typically it's one or the other. And what they did was, they said, all right, I want to have one leg do exercise to volitional failure with BFR. And we already know that exercise to volitional failure with or without BFR is going to induce maximum amount of muscle hypertrophy, as long as loads are 20 to 30%, typically with BFR. Which is actually, by the way, before I go on, a really cool observation, which is, what we understand about resistance exercise normally is that when you are exercising about 30 to 40% of your 1 rep max, as long as you're carrying out exercise close to or achieving volitional failure, you will get equivocal muscle hypertrophy as if you were lifting 80+% of your 1 rep max. But in low load exercise at 20% without BFR, it looks like the hypertrophy is a little bit less than what it would be at 80% of your 1 rep max. However, if we add blood flow restriction to this, we get equivocal growth at 80%. So now we just lowered the floor about 10% of your one rep max, which may have significant impacts on those that are injured to be able to replicate that high intensity strength training stimulus. So that is really what's cool about BFR resistance exercise. And we also get a similar effect with cardiovascular exercise, which kind of lowers the floor for aerobic adaptation, which is super, super cool. But anyways, to get back to my example, just to finish it, what they did was they said, all right, I want you to exercise over the course of, I think it was 8 weeks. I want you to exercise to volitional failure with one leg. And then all we're going to do is we're going to go and we're going to do 75% of the total reps on the opposite leg. So we're operating 25% away from failure. And what they found was significant muscle growth, significant muscle strength, pre to post with no difference between conditions, and the perceptual demands, which are a huge barrier to long-term blood flow restriction practice, were significantly less in the 75% to failure group versus the failure group.
Wow.
And massive. It goes back to, do we need to operate at such close proximity to muscular failure? I don't think so. But when we're teaching BFR and we're thinking about how it operates, I do think that if I'm going to make a recommendation, I'd rather be closer to than further from volitional failure. If I want to say, all right, Nick, what if you're going to give me one prescription, what is it going to be? I'm going to say you want to operate within a close proximity to muscular failure versus 25% away from muscular failure. So that just means that the window is super large. And these were largely untrained recreational and active people, right? So they're not athletes. I think that the precision that we need to have increases when we are more and more trained in a particular mode. And that should make intuitive sense because we're going to need more of the stimulus in order to get that benefit when we are relatively more trained rather than less trained.
It's super interesting. One last question about the devices is I understand that Katsu has inflates, deflates. There's a cyclical mode. And as I was explained earlier, and maybe I'm wrong, is that as it's inflating and deflating, there's also an increase in pressure kind of up and down. I don't know if any other devices have this, but is this something magical and would have much better effects on some, I don't know if it's muscle or heart or something like that?
So I think the best question would be to ask the people with Katsu that. However, I will give my explanation or my understanding. So what the goal there, first of all, I think it's a patented cycle program. So I don't think anybody can do repeated inflation deflation cycles anyways. And so the goal there is you're trying to give almost like a progressive overload to your vascular tissue. So you're starting out at a low pressure, then you're increasing it over time. And what's happening is every single time you increase the pressure, you're creating what's called reactive hyperemic response, which just means that you have relatively oxygen-starved tissue that is distal to the cuff application. And you have this restriction of blood flow, even if it's a little bit of restriction, and you lose that restriction. Now you have this rushing of blood in the conduit artery, which then gets dispersed, as we mentioned before, in examples of multiple different avenues. It ultimately reaches the muscle, but that creates shear stress. So shear stress is, like you can imagine, like the highway, keeping with that same example, the highway, trucks are normally going 40 miles per hour. Okay, great. Everything is good. Now with the restriction, they were now from 40, now they're at 20 miles an hour. And then when you release the cuff, now they're at 60 miles an hour. So you're getting this increase in blood flow velocity that gets registered by these small cells called endothelial cells that line the arterial wall. They sense that change in blood flow velocity and they release these vasodilators, which allow for the artery to get a little bit bigger, in essence, to accommodate this increase in blood flow velocity. To then, over time, this stimulates a bigger artery. And when we have a bigger artery, like more wide artery, that allows for healthier that's a healthier vascular tissue because now we're able to deliver more blood flow to the limb. And so repeated inflation and deflation is simply we're accommodating for basically trying to create more and more of this reactive hyperemic response over time. And when we do that, just saying, when you're doing day-to-day exercise, you're now restricting arterial flow, you're increasing oxygen demand, you're doing all those things that will give you that vascular adaptation that you're looking for.
Then the question would be, is there any research on, I guess you could manually do these things as well, but maybe not as efficiently, but would it have Would you
So
have?
it's funny because I actually just saw like a couple weeks back a paper on the Katsu cycle mode in individuals doing aerobic exercise. It's on my reading list, but that was the first time that I've seen Katsu cycle actually in the research. And just from skimming it, it looks like it does what you'd expect it to do. It increases tissue deoxygenation. It does what you would expect it to do. But it was just funny that you mentioned that because I'm trying to get a project on repeated Katsu cycles and seeing the acute to chronic change and whether or not that impacts performance without exercise. So doing that a couple times a day over the course of 2 to 4 weeks and seeing does that influence repetitions to fatigue, does that influence workload capacity, et cetera, to try to measure some of the vascular changes that are purported to occur with acute to chronic use of the Katsu cycle program.
But I think Katsu has probably one of the most researched in terms of devices. Maybe I'm wrong, but
No, they do. I personally have not. I've seen Katsu inflated in a constant type of pressure. So when you look at these Katsu studies, they inflate to an arbitrary pressure, typically 160, and then they'll increase the pressure over time. So they're using constant mode. They're not using cycle mode when
why
they're
that's
doing
strange.
these studies. I've looked for them. So I have, unless I've missed studies, which is, by the way, totally possible, I have not encountered studies other than the one that I just said, like that was 2 weeks ago. That's why it was so novel, that have specifically leveraged the Katsu cycle program as what they're doing. They recommend the Katsu cycle program for day to day, but the studies that I've looked at have typically adopted a continuous type compression program in their interventions, and they increase the pressure over time.
Why wouldn't they study the cycle mode? Because that's a unique selling point. It's
I don't know. That's where, unless it's written, I'm friends with a couple of individuals in the Katsu company, and they said that it might not be written as a cycle as such, but it was using cycle in some of these programs, but it's not explicitly
written down on
again,
paper.
I might be completely off base. And if there are multiple papers that I've missed, by all means. But generally, the ones that I've come across have been inflating to 160 millimeters of mercury. You're going to do an exercise intervention. All right. The next week, it's going to be 180, then 200, then 220. So I haven't yet. And that's why I'm so interested in trying to get Katsu cycle research out there. My job is I want to deconstruct the marketing from the science.
Okay, I could talk to you about BFR forever. So we're going to wrap this up, and I want to go into a little bit of grip strength. But before we do, what are the most important things that someone should really consider when they're looking to buy a BFR device?
Big question. I personally buy whatever you want. It is what it is. You have to take the pros with the cons. It's impossible to just make a blanket statement. However, the clinician in me is going to say, if you're going to use a single chambered cuff, you probably want to have a cuff that has been validated, meaning that they're applying the pressure that, so say your limb occlusion pressure is 180, that it actually is 180 versus 220, or even in a worst case scenario, 130, 140. So now, when you set your pressure, you're not supra occlusive, because there is a small risk to exercising in supra occlusive pressure. So you want to make sure that you are sub occlusive. So cuffs that have been validated, that automatic cuffs that have been validated, like the Delphi personalized tourniquet device, smart cuffs, even air bands, which are more affordable. They're like semi-circumferential, meaning they don't have a bladder that completely encompasses a limb, but they have been, for better or worse, validated in terms of the amount of applied pressure that they're at. If you're going to use a manual cuff, try to make sure that you're at least doing an accessory type measure, so you're not exercising super occlusive. That means feeling your pulse. You can use a pulse ox, for example. That's another way that you can do it. You can just put it on your arm, put it on your finger, and you inflate. And then as soon as the pulse ox is away, wait a second and then slowly deflate until you get the pulse ox again. And that'll give you your limb occlusion pressure, plus or minus 10 to 15 millimeters of mercury. And then make sure you're not having any numbness or tingling. Or you can just buy one of these cuffs where the stimulus is not going to be the same, but it's not
That's
a
a
safety concern.
multi-chamber.
That's a multi-chamber. Like typically I recommend people in fitness to use either an automatic cuff that's calibrated, that's validated, like Smart Tools, for example, or if they don't even want to bother with any of that, then the multi-chambered cuff. And then again, we can get into nuances associated with application recommendations, et cetera. But generally that's my recommendation.
Okay. So choose which kind of chamber you want, single or multiple, with those considerations as well. Automated is probably a little bit easier. And then, of course, there's comfort and price. That some of these things are really expensive. You can try one out. It's even better. I always recommend if you could borrow one from a friend or your physio, and then you see what they're like, that'll help. Thank you so much. You've given so much clarity on the choices out there and the differences. And the good news is you'll get some results. It's just a matter how you want to get there. But I want to quickly move on to grip strength, because you're, physiotherapist, and you know that this is really an important marker, and it's something that research does a lot on older adults, and they have this correlation between grip strength and mortality. How does grip strength predict when we will die, if it's true, and why is this measured?
So first and foremost, grip strength is a nice surrogate for total body health. I think, anybody that's going to sell you on grip, generally the people that have better grip are harder to kill and thus are more healthy and generally physically active. So it would be disingenuous of me to say that grip strength is going to give you the mortality boost that will change your life. However, it definitely could improve your ability to function in day-to-day life, right? If you're stronger, grip is stronger, that allows you to hold more things, etc. And then obviously with its relationship to exercise and being able to do more in the gym, that's super important. For me, grip strength from an aesthetic perspective has always been something that I've been interested in, but I ended up taking over this company called Sport Grips that has a portable wrist roller. If anybody ever thinks about the wrist roller where they like in the gym and you see people like with this rope and then a plate attached and they do their wrist exercises. Well, this is basically a portable wrist roller that you can do anywhere. So we took over this company last year. These product lines have been in for 15 years and have their own cult following, but the guy that was the original inventor was never a businessman. So we're trying to take this company to the next level. And it of course is tangentially related to BFR because it's distal to the application of the cuff and it nasty pumps for sure. But this one allows you to adjust the resistance from very light to super intense in terms of the resistance to get to the point where, you're going to have trouble moving it. So it fits a total demographic. Basically 95% of people is what we tell. There's 5% of people that are very strong that we have more products down the pipeline that we're re-releasing that are going to fit their needs. But for a lot of people that would be interested in grip strength and making sure that they're doing what they can to supplement their lifting, but also just having day-to-day life being easier, like this is definitely the Revolution 2.0 is the product. Is definitely something that I'm super passionate about and very proud to be a co-owner and trying to blow this thing up.
I was just telling you before we recorded that I created this reel about why we want to get strong in menopause and midlife to protect our future selves. And it's so hard for us to imagine it in our 50s, what we're going to be like in our 70s or 80s. But it's simple things. I'm a gerontologist. So you see, people cannot open jars. And that's a frightening thing, to be dependent on somebody to open your jars, or you can't carry your groceries, or you have to constantly take a break. And so these are activities of daily living that can tend to go. And I think grip strength can really help with that. And that's why I was like, oh, I wish I had that device to show people, but I didn't. I thought it was important enough for me to talk about it in a reel, that it's so cool that you actually have a device. Because I was trying to rack my head, like, how do we practice our grip strength? And I thought, well, hanging, I don't know if hanging does anything.
It does, but yeah, this is a nice supplement. I'd be happy if Sport Grips is the website. If they just use a code, let's just make it hack my age 10, give them $10 off for using it. And so at least check us out, because really I'm involved in a lot of different things and I don't pump anything, no pun intended, that I don't fully believe is the best product out there. And so that's why it's super cool to be able to try to blow this thing up, but knowing that like it is the best on the market. Even our reviews, if you go to Amazon, you go to our Google reviews, you can read all about it. Like it is the best. And that's what's super, super cool, is because for me as a physical therapist and a personal trainer whose goal really is to help people feel better, look better, improve their longevity, there's nothing more important than exercise. And certainly what's funny is my wife she was the lead researcher in terms of understanding what people say about grip strength from a fitness perspective, and people don't do it. So our motto they don't do it for a number of, they don't do it because they're like, oh, I get my grip strength when I do exercise, which is partially true for sure, but they're muscles, much like anything else. You're doing an isometric contraction when you're gripping. You're not doing a dynamic contraction. And certainly with this device, a lot of people are familiar with doing this, right? Which is great. It gives you resistance in both directions, but a few people realize they actually can do key turning, right? So they work on pronation and supination, which is often forgotten. So our motto is don't skip the grip. And we trademarked it, we got it. And really our protocol is super simple. And we want to make it accessible, and I want to take away the complexity. So people ask, oh, what do you do? Well, it's simple. You take a resistance, you put it to whatever level you want, right? A moderate resistance is what I say. And you adopt whatever position you want. So typically there's a number of different positions. We have 6 different types of positions that you can use. 20 seconds on as hard as you can, because we want to replicate that intensity, right? And 40 seconds off. Repeat that 3 times. So in 2 minutes and 20 seconds, your forearms will be so fried, you're going to have trouble picking up your cell phone. You're going to have trouble handling objects for 5 to 10 minutes after. And it's insane because you're getting pretty solid resistance on both ends of your forearm, whether it's turning, whether it's flexion and extension. And so it really is the program. Because remember, if everyone skips the grip, we want to create a protocol that's accessible, that's easy, that's able to be progressively overloaded. So you can use these as resistance markers, but generally the way that we do it is just 1 turn. All right, that's 1 turn. Maybe next week you try 2 turns and things like that.
I actually, another practical, I reminded me yesterday, I had a personal trainer and I was doing on the machine, just pulling, I think I was working shoulders more or less, or back. And I fatigued because my forearms hurt. And you would think, oh, well, that's another practical application. If they were just stronger, I would have been able to go a little bit longer because, well, I never practiced my forearm. So thank you. I'm going to have to get my hands on that. And
yeah, for sure.
I love it.
Definitely we'll get you it before so you can at least have some honest thoughts on it.
Yeah, yeah. No, thank you so much. And I'll have a link to get it and with the $10 off with Hack My Age 10 in the show notes. And you can go to sportsgrip.com and check it out right away if you cannot wait. And before I let you go, what's the one thing that you learned from your experience as a physical therapist that you apply to your own health practice?
You need to be consistent to have results. I believe that the best patients that I have are the ones that are consistent. They're consistent with what I tell them to do. They do it, and that gives us data. And data allows us to it informs decision making. Being able to take that is the most valuable thing that you could ever do, because you'd never want to make decisions that are without any sort of data. That feeds into some of the BFR conversations that we've had. That feeds into some of the sport grips conversations that we've had about grip and everything else. And so for me, I hold myself to that same standard. I track my workouts. I make sure that over the course of a training cycle, I'm increasing my volume, or am I increasing my intensity more so than volume? But sometimes I add a set. Why not? And to try to get to point A to then get to point B versus point A to point B on the same line. We want to always start to increase our workload. And how do we do that? We need to be consistent. And so that's kind of what I tell my patients. If we're hitting a roadblock, I consider myself pretty good at what I do, but I don't help everyone. But the only way that I know that I can't help you is if you are consistent and we have data that suggests that what we're doing is not working. If we don't have an alternative strategy, boop, you're off to see somebody else who can potentially help you. We need to have consistency to be able to do that.
Ah, I love it. That is such great advice. If anybody wants to reach out to you, they can find you at, well, they can email you. I have an email, but also the HPM. You also have the BFR Pros and Sport Grips on Instagram, and go check out the website as well. But thank you so much, Nicholas. You've cleared up a lot of confusion, unbiased information on BFR, which we all need and want. And I think I can still have the conversation of BFR. So hopefully we'll have you on again. And thank you everyone who's listened to the end of the show. You're obviously just as interested in this topic as I am. And thank you, Nicholas. Have a wonderful day.
Thank you so much for having me on. Really appreciate it.